Hello, everyone, and welcome to CancerSpeak, the official podcast of the American Cancer Society journals. I'm Ruth O'Regan, your host for today's episode. I serve as a deputy editor and breast disease section editor for the journal Cancer. I'm also the chair of medicine and a breast medical oncologist at the University of Rochester in Rochester, New York. I'm very pleased to be joined today by Dr. Carrie Sha, Dr. Andrew Epstein, and Dr. Yael Schenker to discuss their recent commentary published in Cancer, which highlights major advances in palliative care and supportive care in oncology over the past year. Carrie, if you could just tell us a little bit about yourself and what your research interests are.
For sure. Thank you so much for having me. And I'm very grateful for this opportunity to discuss our work, especially on this platform. I'm currently a chief medical resident at Memorial Sloan Kettering Cancer Center in New York. I trained at Cornell as a medical student and also as a resident in internal medicine. And I'm going on to hematology oncology fellowship at Columbia this July. My research interests are particularly in oncologic palliative care delivery. I've been working with Dr. Epstein for the last few years, and I'm also interested in the care of older adults with cancer.
That's wonderful. So you're staying in New York. Congratulations on matching there. That would be great. Andrew, do you want to go ahead?
Sure, and I'll just start by piggybacking off of what Carrie was humbly talking about. It's a wonderful example of a smart, motivated, and lovely person to work with as a mentee. So Carrie's done a wonderful job on this and other work, both clinically and research-wise. And I came across Carrie because I work at Sloan Kettering as a GI medical oncologist, where my research focuses on the interface of medical oncology and palliative care, which is a field that I have a fellowship training in, and focus my research at communication and care delivery and advanced care planning. So excited to be here and appreciate the invitation.
Yael, did you want to tell us about yourself a little bit?
Absolutely. Thank you. So my name is Yael Schenker. I am a palliative care physician and a health services researcher. I am newly the chief academic officer at Denver Health, which is an amazing academic safety net institution in Denver, Colorado. For 15 plus years, I was a palliative care researcher at the University of Pittsburgh and really focused my career on how to improve delivery of palliative care, primarily in cancer. So I've had the privilege of knowing this amazing team, particularly Dr. Epstein, for many years now. And I also am the symptom control and palliative care section editor at the journal Cancer. So happy to be here.
Great introductions. Very nice to meet all of you. So I think we'll start just with Carrie, just maybe talking a little bit about the commentary that you just published. I read it, but some of the audience may not have read it. So if you could just tell us what you highlighted in that commentary, that would be great.
Yeah, for sure. So in this commentary, we really wanted to give a good summary of the top advances in palliative and supportive care in oncology within the last 2 or so years. So from 2024 to 2025. And by doing so, we divided these advances into 3 main themes, specifically 1, optimizing palliative care integration in cancer care, 2, technological innovations, and 3, the treatment of complex cancer-related symptoms. We end up highlighting 6 major papers within these themes. For the first theme of optimizing palliative care integration, we examined both innovative models of palliative care delivery, looking at the Temel 2024 paper that compared stepped palliative care versus early palliative care. We also look at palliative care integration for diverse cancer types. So although a lot of these interventions have been done in the solid tumor setting, we also examined a 2025 paper which looked at a palliative care inpatient intervention in a setting where adults were receiving allogeneic hematopoietic stem cell transplant. For the second theme of technological innovations, we highlight both the use of telehealth and the use of electronic patient-reported outcome, or EPRO monitoring. So in doing so, we specifically highlight 2 papers, one that looked at early palliative care via video visits versus in-person visits, and another that looked at EPRO monitoring versus usual care in the real-world setting. And on the third theme of treating complex cancer-related symptoms, we looked at both the treatment of cancer cachexia and end-of-life delirium. And specifically looking at the drug ponsegromab, which is a monoclonal antibody against growth differentiation factor 15, and its effect in weight gain and cancer cachexia. We also look at a recent paper in 2025 demonstrating the utility of benzodiazepines and end-of-life delirium. So we highlight all these advances to say that they've definitely paved the way forward for palliative care and supportive care in oncology, but there's so many challenges still ahead that we're happy to speak about more in this podcast.
I'd never heard about stepped palliative care before. Maybe could you just explain a little bit what that is? Because I know typically ASCO likes to have palliative care involved in patients with stage 4 solid tumours very early on, but it sounds like that was a way of getting patients involved and then kind of seeing them as needed depending on their symptoms. So I don't know if you could just explain that a little bit.
Yeah, exactly. I'm glad you asked. It's a terminology that's being used to describe what you were saying, that it's done on an as needed basis and not necessarily at one particular time point. So the benefits of doing this is that within a patient's cancer trajectory, there are times that might be especially vulnerable where they especially do need this palliative care involvement, and other times where maybe their disease is stable and they have less of a need for palliative care. And so because we know that, there's a gap in the workplace of specialty palliative care providers, to be able to address this, as the stepped palliative care model would allow providers to intervene on an as needed basis and not so much the same model for everyone early on.
That made a lot of sense to me. And then before we move on to more kind of broader questions, I was interested in the whole in-person versus telehealth as well, because certainly where I am, they do a lot of ambulatory telehealth, but it sounds like it's actually quite patient-friendly and the patients and caregivers really like it.
That's true. For this particular paper, they looked at patient-reported quality of life scores, looking at the early palliative care intervention via video visits versus in-person visits. And they were essentially equivalent in these two groups when they were looking at how the patients reported their quality of life. And then in terms of what we know about telehealth in general, there's certainly a mass increase of telehealth usage in medicine in general, not just in palliative care within the last few years. And in general, telehealth has been quite accepted by patients, families, caregivers, and providers. And I think Dr. Schenker actually was involved in a systematic review looking at this, which she can probably comment on a little bit more.
Yeah, no, I think that's right. And I think, it's interesting. For a long time, there was sort of this pervasive belief that palliative care had to be in person, sitting down, warm touch, hands on, and that technology really wasn't a fit with that. I think we've really disproved that theory. This, of course, was catalyzed by the COVID pandemic, but we've continued to provide palliative care very successfully with telehealth. And it's interesting when you think about meeting patients where they are at. Patients have what we call time toxicity with cancer care, where they spend an inordinate amount of time in medical settings with a diagnosis of advanced cancer. And so the ability to have a visit from the comfort of your own home is actually a very, in many cases, patient-centered approach to providing palliative care.
If I could hop onto that, there's not only time toxicity, which is a real thing in the actual medical facilities, but for transportation toxicity, particularly where I work in Midtown Manhattan, the patients will frequently talk about how it's not only a long commute from upstate New York or other places in our tri-state area, but also just the stress level of finding parking and paying for parking. And so the ability for patients to be in the comfort of their home and have the possibility, depending on the situation and the licensure of the physician, whether it is palliative care or even in medical oncology, is really welcomed, I find, by my own patients.
Yeah, I think we should be using it more. Especially like for patients in clinical trials and they're having to come in for these visits that can be easily done by telehealth. It was one of the, silver linings of COVID, I guess. But just to move on to something a bit more general, and maybe we can hear from each of you just about these. Looking at the current state of palliative and supportive care today in oncology, where have we made progress, but where would you see the biggest unmet needs?
Carrie has touched on a lot of the existing data that we highlighted, and I think the oncology community is aware that palliative care has shown over numerous years and numerous trials an ability through the integration of specialty palliative care services, despite the workforce issues that Carrie mentioned, to improve a patient and caregiver symptoms, quality of life, and even, as we know, to improve overall survival. And I think now what we're commenting on in this piece and where the field is going is the additional ways and nuances and methods that are on top of that foundation about how we can help patients and families feel better and live longer, both in terms of technologic development use as well as mechanistically, as Carrie was talking about with cachexia trial. So certainly many areas to go, but I think that it's clearly here and really an exciting time for building on that foundation and in the future actually continuing to show additional ways that we'll talk about that apply not only to specialty palliative care delivery, but what the palliative care from the actual primary oncology team itself is being given, as we medical oncologists and even surgical radiation oncologists and others who are longitudinally caring for patients provide every day without, or at least in addition to, the specialty palliative care that's been mentioned.
Yeah, I absolutely agree. I mean, I think about what the field of palliative care has done in the last 15 to 20 years. And I think we've really figured out what works. And now we have a challenge of how do we get that to the people that need it. And I think we still have some really significant implementation challenges, is maybe the best way to put it in palliative care. We have this evidence to practice gap. And I think we need to be thinking more broadly about our population with needs. Clearly, our specialty palliative care workforce is not equitably distributed. We have many patients in more community settings, more rural settings that simply don't have access to specialists and for whom some of these access challenges are significant. So I think it's really, starting with what we know works and then with where people are at, where our patients are at, and looking at some of these different ways to deliver palliative and supportive care and really addressing the implementation challenges. That for me is the exciting next stage of the field. And I'll also say that, we are in this place thanks to the incredible therapeutic and technologic innovations in oncology. We have people living longer and longer with advanced disease. And so as we see that, focusing then on quality of life, on symptoms, on patient-centered care, on goal concordant care, and leveraging those therapeutic and technologic innovations to address some of those, patient and family-centered issues, which we know are so important. That's, for me, the exciting next stage of the field.
Yeah, we have a very rural catchment area here, so trying to work out how to provide palliative care is definitely something that is a challenge, but really, really important. And I think just going along with that, Carrie had been talking a little bit about the electronic patient-reported outcomes. Thoughts on that? Is that something that we should be doing routinely for everybody, or is it still kind of more on a research side, quality improvement side?
And so I think there's a lot of research that's still being done on EPRO monitoring. And I think one of the issues is that there's a lot of really good data, and there's a vast amount of data that can be collected through EPRO monitoring, which is an advantage in some ways. Patients don't need to necessarily wait until their clinic visit with their oncologist to report the symptoms. They can report it in real time, and they're more likely to remember their symptoms in real time. So while that offers an advantage, I think one of the key clinical questions is which data points are actually clinically meaningful, because we're getting so many different points here, and for which cancer populations and at which point in their cancer trajectory. I think once we have a better understanding of which data points are clinically meaningful, we can figure out how to best integrate them into the clinic visit setting.
Yeah, and I would say as the real world data that Carrie touched on is certainly a step above the other excellent randomized trials done by Ethan Bash and others, it's still necessary, as Dr. Schenker was talking about, to have implementation on an even larger scale because of the heterogeneity with which various health systems work. Nonetheless, I think the need is really there. As a busy medical oncologist with some rotation of team members, it is, and a large number of patients, it's still too easy for patient concerns, worries, and symptoms to be missed or to be not delved into or addressed in the most detailed way that they need to be. So any technologic advances, whether it's AI or others, are going to be complicated, but I think a necessary need to investigate in order to make sure that the needs of patients and their families are being met as patients are living longer with cancer, as Yael also said.
I agree with that, and just want to add that it's also important that we think about how as a system we are supporting some of these technologies that we do see work in research studies. And, we don't have a clear mechanism for sustaining some of those interventions beyond the cycle of a grant. And so as we, really talk about prioritizing the patient experience and decreasing symptom burdens and improving quality of life, we need to think about not only how those interventions work within real world clinical practices, but also how we're going to, support and sustain those kinds of tools for our patients.
So let's move on briefly to talk a little bit about cancer cachexia. And also, Carrie had mentioned also about the management of delirium in patients at end of life.
I think we've all seen the age-old challenge, distressing and symptom-related challenge of cancer cachexia, and we're thrilled to really see the magnificent proof of concept in the New England Journal of Medicine article that Carrie had mentioned. And as she had also mentioned, additionally exciting is the fact that there are trials, including one underway, the phase 2/3 RIVER MPDAC trial, which takes patients with metastatic pancreas adenocarcinoma who are receiving first-line chemotherapy, and is going to check really not just, in a vacuum of if they gain more weight, but it's really a where the rubber meets the road trial to look at if this can help these patients receiving first-line chemotherapy tolerate treatment longer, feel better, and ultimately live longer. Also, interestingly and importantly, it simultaneously assesses how much burden it lifts off their caregivers, because I think that we've all seen as clinicians, whether we're oncologists or palliative care physicians, the tremendous concern that loved ones have for patients when they see them having cachexia, and the desire for us to nourish our loved ones who are patients, to have them eat more and gain weight. And so it's not just the effects on patients, but families and the clinicians too. It can really be uplifting to see the weight gains and other outcomes that are going to be studied to improve. And so it's very exciting for that to come out. There are other details that are in those trials, but it was also great to see that there's not really significant side effect profiles that are being messaged in the readouts of these trials so far.
Yeah, I completely agree with you. I think it's one of the toughest conversations we have with caregivers is when they see their family member losing so much weight. So I think it's so important. And then with the delirium paper, any take homes from that? Because again, I think that's something that certainly as oncologists, I don't know that we're great at managing that.
This paper was looking specifically at delirium near the end of life, which I think is different from how many of us perhaps think about treating delirium, and sort of the standard teaching that you don't use benzodiazepines for delirium. Delirium near the end of life is such a distressing symptom, particularly for family members who are watching that kind of agitation, restlessness. And so to have a study that actually shows, first of all, to have a study focused on this population is, in my mind, really terrific. And then actually to see an improvement, particularly with the lorazepam groups, just gives us another tool in our toolkit for how to really focus on patient symptoms and distressing symptoms in that population.
It's so important. Any final thoughts? We've kind of talked a little bit about where we think the field of palliative care is going and how important it is for our patients. But I don't know if there was any other thoughts, that something that we hadn't discussed that you wanted to just chat about briefly.
I touched on it a little bit, but I want to reiterate, and I'm biased because this is my area of personal interest clinically and in research, is the role of primary palliative care, which, as Carrie had delineated in the commentary, is that delivered by the primary team, either instead of or in addition to specialty palliative care services by the consulting palliative care team. And really excited to see data come out, whether it's from the Temel group in terms of the SCOPE trial with leukemia, primary versus specialty palliative care in that population, and lots of other groups, including Yael had done really lovely work leveraging the trusted role of the oncology nurse in advanced care planning, and in our group, trying to systematize and operationalize from the start of care the assessment and elicitation, documentation of not only patient symptoms, but their prognostic awareness and who they are as a person, what we call their health-related values. And we hope soon to have NCI funding for a randomized trial, given our results that seem to show the improvement in patient-reported quality of communication when oncology teams themselves, whether it's the oncology practice nurse or even using the portal to assess what's important to people as patients with cancer. And so it's been exciting to see that this is feasible and doable, especially with technology like the portal, and may move the bar in terms of things like the ratings of clinical care quality, and hopefully will help with other things, whether it's trust, quality of life, anxiety, and depression. And so I think that medical oncology and other primary oncology teams have a tremendous amount of things on their plate, and yet they have the duty to meet patients and families where they are. And there's a lot of pressures economically and other with the delivery of cancer care, at least within medical oncology, and yet that need exists. So hopefully technology and other implementation studies can move the bar. And then finally, I'll say on the other end of early elicitation of how people feel and what's important to them, I think that telemedicine actually can be used more and should be studied more. And Carrie's been involved in a different thread of work with how can we use things like telemedicine to smooth and continue the transition from cancer-directed tests and treatments to a full and exclusive focus on comfort at the end of life, such as when the hospice transition needs to occur. And I think telemedicine, even though there's a lot that still needs to be ironed out in terms of coding and templates and who does what and who's the hospice physician of record, I've personally found it very rewarding as a medical oncologist, and I think helpful for patients and families to be able to have telemedicine visits with me while they are receiving hospice care, or at least while they're considering hospice care, in order to better smooth that transition, which, as we all know, can be a very challenging one for clinicians, families, and most of all, patients.
I think they're excellent points. I did quite a bit of palliative care training when I was a hem-onc fellow. I don't know that it's done as much now. I don't know. It's kind of fallen off, but I do think it's so important because we're the ones that really start the conversation.
Speaking from a chief resident perspective, also, we are doing more palliative care and supportive care related education, at least for our medicine residents, and being able to introduce that so that, we know that most of these residents are not going to end up becoming specialist palliative care providers. I know they're going to be cardiologists, oncologists, GI docs, et cetera, et cetera. But no matter what field they go into, hopefully they can take away some of these very useful skills and be able to perform primary palliative care for their patients.
Yeah, for any chronically ill patient, right? Absolutely. It's a very good point.
I could not agree more about the importance of primary palliative care, and thrilled to hear that from both Dr. Sha and Dr. Epstein. I think also, just to circle back to the telehealth opportunities, we have flexibilities in telehealth resulting from the COVID pandemic. We have the opportunity to make those policies more permanent. And so that's something we should all have on our radar. And then I think, just to say, again, what we've all been saying in many ways is that we need palliative care to meet patients where they're at, and we need to include in that our most vulnerable patients. And, recognizing again that most people aren't coming to NCI designated cancer centers. Many people are living in parts of this country where access to a specialist is really a challenge. So making sure that we're designing our trials and thinking about these access challenges with that broad lens, for me, is a really important next stage for our field.
That's all the time we have for this episode of CancerSpeak. I want to thank Carrie and Andrew and Yael for taking time out of your busy schedules to join us today. Special thank you to the listeners who tuned into the episode. And of course, we encourage you to read the Top Advances of the Year, Palliative and Supportive Care in Oncology, which is now published in Cancer. We will include a link to the publication in the show notes.